welcome back to my channel. So today I'm gonna solve with you guys ophthalmology questions on AMBOSS. I'm on my ophthalmology rotation right now, so I guess the information is fresh. So this is step 2 CK, but the questions are very similar to step 1. It doesn't mean that similar questions wouldn't come on step 1 as well. So yeah, we're gonna choose ophthalmology. Okay, I'm gonna choose ophthalmology with you guys. Remember that these are very similar to step 1. You can get similar questions as well. I'm gonna do 5 questions in exam mode. Alright guys, so here's the first question. Like I always tell you, I read the last 2 lines. They give away so much information that can help me solve the question without even reading the whole thing. So with spectacles, the visual acuity is 20/20 in left eye, 20/100 in right eye. So obviously her right eye is the one affected. Slit lamp shows no abnormalities. A CT scan of the head shows no abnormalities. Which of the following is the most likely diagnosed? So I didn't reach anything by reading this, so I have to read from the start. A 33-year-old woman, middle-aged female, because of vision impairment in her right eye. We already know there's something wrong in her right eye for the past 2 weeks. During this period, she's unable to distinguish colors and reports pain with eye movement. Guys, you have to understand that colors, distinguishing colors is a function of the optic nerve. And just from the get-go, off the top of my head, this is a middle-aged female, and she has something wrong with the optic nerve, right, in one eye. Right away, something that just popped up in my head, which is multiple sclerosis. She might be having multiple sclerosis, which very likely presents with optic neuritis as a first presentation. Pain with eye movement here is a result of this being retrobulbar. There is a form of optic neuritis. There is retrobulbar, which means that behind the orbit, there is inflammation behind the orbit where the extraocular muscles are, and so she will get pain with eye movement. She occasionally has headaches, and similar episode affected her left eye and resolved spontaneously. Whenever you find previous episodes in a middle-aged woman, you always have to suspect multiple sclerosis because they are spread out in time and space. It means that she might as well have got previous episodes before. She has no history, works in library, whatever. Pupils equal round, reactive to light and accommodation. Without correction, visual acuity is such and such. So now I already diagnosed this as optic neuritis. So yeah, it's the correct answer. Caused by multiple sclerosis, and it's one of the earliest manifestations. As you can see, more common in women, age 20 to 40. And color blindness is almost a giveaway. Note guys, what is highlighted here? What is highlighted here is the demographic. This helped us narrow it down a little bit to multiple sclerosis. What's highlighted here is vision impairment and another episode. Just like I told you. Middle-aged woman, vision impairment in one eye, and she had another episode. Those 3 pieces of info are key to reaching the correct diagnosis. So always look at what AMBOSS highlights. Alright guys, moving on to the next question. Again, I'm just going to read the last 2 lines. Slit lamp exam shows lens subluxation, the supratemporal direction bilaterally. Which of the following is the most likely underlying cause? So right now I know there's lens subluxation up and out. That's what we mean by supratemporal. So I didn't reach anything. A 3-year-old boy is brought to the physician by his parents for a well child exam. Guys, so if I just skim these, just by skimming these choices, I've already reached the diagnosis already. Oh my god, yeah, because lens subluxation in the upward direction not the downward direction, the upward direction. In a 3-year-old must be something hereditary, must be something congenital, right? And the choice is showing me a lot of genetic causes. We know of 2 conditions. There's only 2 conditions here that are genetic, which cause lens subluxation. Either homocystinuria or Marfan syndrome, right? One of them causes subluxation down, and one of them causes subluxation up. The one that causes subluxation up is Marfan. I did not finish the question. This is what you should be doing, guys. Save your time. The questions, they just throw in a keyword or 2, and that's what's essential to reach the answer, and that's it. So what causes lens subluxation up is Marfan. So what is the underlying cause of Marfan syndrome? Now this requires a little bit of step 1 info. So from what I remember is fibrillin 1, I guess. This will be homocystinuria. This collagen cross-linking, I can't remember. Of course not. Non-disjunction. This will be Down syndrome. So yeah, it's fibrillin 1. And take a look at what is highlighted, what is essential to reach the correct answer. Thank God I highlighted this, because essentially that's the thing. Lens subluxation, the supratemporal direction, congenitally, just by skimming the choices, that's it. But if you were to read the rest of the question, you would see severe short-sightedness, myopia is one of these signs. 97th percentile for height, they usually are very tall, with ectopia lentis up and out. Here's the supratemporal. They have long fingers, spinal deformities, among so many others. By the way, this test, I'm gonna look for it here, abnormal long, slender fingers and toes. So yeah, patient presents with severe myopia here, tall stature here, high arched palate here, okay, arachnodactyly, long fingers right here, and supratemporal lens subluxation right there, okay. Moving on. Okay, so I'm again gonna read the last line. Lab studies show a leukocyte count of 12,000, which of the following provides the strongest indication for administering IV antibiotics, intravenous antibiotics. Okay, so I didn't reach anything. I just learned that there's an infection somewhere, since this is a high leukocyte count. Let's move. A 22-year-old woman is brought to the ER because of a one-day history of double vision, rapidly worsening pain, swelling her right eye. So she's double vision, pain, and swelling. She had an upper respiratory tract infection a week ago, after which she has had nasal congestion, recurrent headaches, perinasal discharge. Guys, always translate the clinical picture into a diagnosis. What does it mean that she had an upper respiratory tract infection and then after that she got this? That means she has sinusitis, okay? So you always have to translate all the fluff into one piece of info to make things easier. So she has sinusitis, and after that she got something in her eye. What do you think would be the diagnosis? Without finishing, it's orbital cellulitis, guys. She had sinusitis and now she's having double vision, pain, and swelling her right eye. There must be a spread of infection, right? But I'm still going to continue. She took antibiotics for her respiratory tract infection but did not complete the course. Okay, so again, it goes in line with our history. She has asthma treated with, this is distraction, okay. She appears to be in severe distress. Her temperature, she's feverish. Pulse is 100, okay. Ophthalmic exam, the right eye shows proptosis. Now, this is a very specific sign for orbital cellulitis. Diffuse edema, erythema, and tenderness of the eyelids. Again, right eye movements are restricted. The fact that movement within the eye is restricted indicates there's an orbital problem, because the extraocular muscles are inside the orbit, guys. The fact that movement in the eye is painful or restricted means there is edema, or the inflammation involves the extraocular muscles, which are in the orbit. So something is wrong there. Pupils are equal and reactive to light. Tenderness to palpation the right cheek, and purulent nasal discharge. Here he is proving to you she had sinusitis, and this is probably the culprit. And now back to our leukocyte count. So obviously she has orbital cellulitis, which is treated by intravenous antibiotics. But there's another differential for orbital cellulitis, guys, which is preseptal cellulitis, which also presents with fever and eyelid edema and tenderness, all these stuff. Now, what is specific to orbital cellulitis that will make you differentiate and therefore give intravenous antibiotics? The fact that she had proptosis, guys, means something is pushing behind the inflammation. The orbit is pushing her eyes out. Proptosis is not seen with the preseptal. The fact she had pain with eye movements means that inflammation is involving the extraocular muscles inside the orbit. This is not found here. The orbit is completely free with preseptal cellulitis, right? So those two signs in particular, plus double vision, obviously, because of the restricted eye movement. Those particular specific symptoms indicate that she has orbital cellulitis rather than preseptal. Now, why does that even matter? This matters because if it were preseptal cellulitis, we will give oral antibiotics. But because it's orbital cellulitis, we have to give intravenous antibiotics. So the question essentially wants to word it like that. What is one sign that shows me it's orbital cellulitis? What is one sign here that is specific to orbital cellulitis? It's as if the question wants to ask you this, but instead he's asking you which is the strongest indication for administering IV antibiotics. So here I'm going to pick the answer choice that has the most specific sign for orbital cellulitis, which is pain with eye movement. It indicates there is something wrong in the orbit and not outside it. Alright guys, so that's it for today. I hope this video helped and give you an idea of what ophthalmology questions can look like. By the way, this can also come up on step 1, not just step 2 CK. So yeah, all the best.